Hello, and welcome to this edition of a video Viewpoint, Roundtable expert discussions on CML clinical debates. My name is Jorge Cortes. I'm from the Department of Leukemia at the University of Texas MD Anderson Cancer Center in Houston. I am joined here today by my colleagues and friends, Michael Deininger, who is Chief of the Division of Hematology and Hematologic Malignancies at the Huntsman Cancer Institute, University of Utah, and by Jerald Radich, who is Professor of Medicine at the Fred Hutchinson Cancer Research Center. Welcome, guys. Hi. What we're going to be doing today is going to be reviewing a couple of cases that I think help us understand some of the challenges that we face today in the management of patients with chronic myeloid leukemia. The first case is something that's very topical today. What is the optimal frontline therapy for patients with chronic myeloid leukemia? So let me present a case, and we can discuss some of the important issues on a patient like this. We have a 47-year-old teacher that is found to have an elevated white cell count on just a routine test. The white cell count is 53,000. The platelets are also elevated. The peripheral blood baths are 6%. There's 2% basophils and large spleen. And just for reference, the patient has diabetes that's well controlled with insulin. So with this, you suspect chronic myeloid leukemia. And the first question is, what is your recommendation for initial workup for this patient? What kind of tests should a physician nowadays do for a patient that they suspect chronic myeloid leukemia? Michael, do you want to?
Well, first of all, do a complete clinical exam, which has happened in that case. So determine the spleen size, look for extramedullary disease, and get a complete blood count, record the differential, and then do bone marrow aspirate and cytogenetics. And I think it can actually stop here because this is the baseline information. Some people would recommend a trephine biopsy. You can do additional tests, but the baseline is really the cytogenetic evaluation in the aspirate.
But would you say a bone marrow aspiration at diagnosis is necessary on a patient?
I would absolutely support that, yeah. Okay,
good. So that patient had a bone marrow aspiration, and the results show that there's 5% blasts, there's 3% basophils. We get the results of the cytogenetics, and it shows a translocation 92211. All metaphases have these abnormalities. And then you also sent a FISH, and you have this 98% of the cells have the fusion signal, but they also report that there's a deletion of the derivative 9 gene. So, Jerry, can you tell us a little bit about these findings? There's this funny translocation, there's this deletion of derivative 9. What should I?
This would be considered a variant translocation, which, as opposed to normal BCR-ABL, which is the reciprocal translocation in 922, it involves actually a three-way translocation, so that all the chromosomes will have parts of these. And so this, in a sense, is different than clonal evolution, where you get an additional chromosome in addition to 922. So what we know about these complex translocations is they aren't associated with a worse prognosis as opposed to those that have an additional clonal abnormality. So this would be a standard risk case as far as risk of their assigned with their chromosomal status. As far as the derivative 9 goes, that's been shown to have a poor prognosis in cases that are treated with interferon. The literature was at first a little bit variant with the tyrosine kinases, but I now think everyone is pretty much settled that it's not a poor risk case in tyrosine kinase therapy nor in transplantation. So I think that we could approach this patient like a standard risk chronic phase CML patient.
Okay, so it sounds like a straightforward chronic phase, chronic myeloid leukemia patient. So is that what I should understand, or is there anything here that tells you that this could be an accelerated phase or something funny, Mike?
Well, it's certainly not accelerated phase, but there are a couple of features that could mean that this is not just the garden variant of CML. There are blasts in the peripheral blood, the spleen is large, platelet count is elevated, the patient is a little bit older. So these are all features that, according to so-called risk, would probably end up with intermediate so-called risk, or if not high risk. So chronic phase, yes, but a little bit on the higher side of the risk.
Should we pay attention to these so-called risks? I mean, it's a very old risk classification. I mean, that comes many, many years ago. Does it still matter with the tyrosine kinase inhibitors and all these?
You know, I think so-called did a pretty good job because that score still holds. When it still predicts with a high level of inaccuracy, admittedly, but it still predicts outcome to some extent. I mean, you can't rely on that, and it's not very precise, but it gives you some hints as to what the individual risk of a chronic phase patient might be.
And I think when you think about CML, you never know when people really first acquired the Philadelphia chromosome and how long they've had the disease. And we know that the longer you have unopposed B-cerebral signaling, the more likely you are to go into progression to accelerated phase and blast crisis, which is what all of our therapy has to be right now to fight that getting from people getting to accelerated phase blast crisis. And since you don't know when the disease really started, the only thing that tracks with time is white count and spleen size. And it probably doesn't track perfectly, but probably the higher the white count is, the bigger the spleen is, probably correlates reasonably well with how long the disease has actually been brewing. So in this one, you'd have to say they have chronic phase disease. You can't say it's late chronic phase disease because that's usually defined by, in studies, as how long it's been since actual diagnosis and starting of tyrosine kinases. So you'd have to just call this a garden variety chronic phase, but it smells like a little bit higher risk disease.
Okay, yeah, that makes sense. Okay, so we have our patient then, and you know that this patient has a healthy brother and sister. They're same father, same mother. Now this is a dilemma that physicians face today because we have several tyrosine kinase inhibitors, and the question is, how do I treat these patients? Do I use imatinib, and there's been studies with higher doses of imatinib? Do I use dasatinib? Do I use nilotinib? Do I do a transplant? It's a young patient with potentially a donor. Are there any other options to consider? Let me get your initial impressions, and then we can go through discussing some of the different options that you may not have chosen. So, Mike, what would be your first choice for a patient like this?
Let me go by elimination. So from the list you mentioned, I would probably eliminate stem cell transplant. In chronic phase, I think the world would agree that exceptional circumstances aside, this is not a first-line treatment because of the associated mortality and morbidity. So we eliminate that. That leaves us with imatinib standard dose, imatinib high dose, or the newer second-line inhibitors. Now I would, in this particular case, I would really be swayed by some features of the disease that indicate higher risk. And I would probably argue that imatinib 400 milligram may not be an adequate therapy. So I would vouch for either dasatinib or nilotinib as the first-line treatment in this case. I'm not convinced that there is a defined space for 800 milligrams of imatinib. The studies that have been performed are a little bit controversial, some showing no difference versus 400 milligrams, some showing some difference in surrogate endpoints. But I think this is really more of a research question at this point in time than solid evidence to give a certain recommendation. So my inclination would be to treat with a second-line agent. Okay.
Jerry, what do you think about this?
Well, even as a transplanter, I would never transplant a patient like this.
All right.
So that's a
good.
My pay has just been docked at the Fred Hutchinson Cancer Center, but nonetheless. And then when you talk about imatinib versus dasatinib or nilotinib, I mean, I think you have to first face the two big phase 3 trials. While they don't show any difference in overall survival between those two approaches, clearly show a difference in progression, with the stronger second-generation tyrosine kinase having less progression, and differences in short-term, at least, cytogenetic responses and molecular responses. It may just be too soon to see a difference in the overall survival. Mm-hmm. And if you decide that the thing that you really have to prevent is people going to accelerated phase and blast crisis, and you assume that people with higher grade intermediate and higher risk cases of chronic phase have a higher risk of going to accelerated phase and blast crisis, I think that sort of puts the onus on you to start a patient like this with second-generation drug.
Okay. Now, one of the aspects that we discussed in this patient was that this patient could potentially could be a intermediate high risk, so-called resistance of the features. Is that what determines that we should treat a patient with a second-generation tyrosine kinase inhibitor as initial therapy? Or let's say that we have a very, low-risk young patient, very little, no spleen, low-risk so-called. should that patient have the consideration of being treated with a second-generation TKI, or that shouldn't be a consideration for that patient? What do you think, Jerry?
Well, I think that it's a little bit more of a gray area. Often when we have this discussion with patients, it goes something like this, that what we know about dasatinib and nilotinib is stronger, faster response, and something that may translate to long-term survival. We know that the long-term data as far as toxicity with imatinib, we've got quite a years of experience now. We don't have that with the second generation yet, even though there is no safety signal that anything bad is going to happen. So lots of times with a low-risk patient, I put it to them like that. I think that it's a stronger drug. I think it probably does give you a little bit of hedge about going to progression. That hedge probably isn't as big a deal in a low-grade disease. But we don't know the long-term consequences with the same amount of certainty which we do with imatinib. And a lot of times, patients will weigh that cost-risk benefit for themselves. And I think that's a helpful way to approach it.
Okay. So what we have today in these results is early responses, cytogenetic, molecular. We have lower rate of transformations. Jerry mentioned we don't have overall survival difference. We haven't seen curves with event-free survival with much follow-up. Is this enough to convince us that this is the way to go for the patients? What would it take for us to say this is a standard of care, everybody should receive it? Do we need to wait until we see overall survival? What would it take? Or do we have what we need?
Well, I would argue it's going to take a long time to see a difference in overall survival because the salvage options are very good. And we may start thinking about CML therapy more as a strategy than about something that needs to be done or has to be done with a single agent. So overall survival is clearly the most important parameter, but we may not be able to see differences. So the question arises, what else? What would be a very strong endpoint that would be applicable to more patients? And here I think we need to look at the ability to stop treatment altogether. And as you know, there are a few studies in Australia and in France in particular that have shown that patients who get treated into a complete molecular response, that means undetectability of the BCR-ABL transcript, and maintain this for a number of years, can actually stop treatment. And about 40% or so of these patients will not have a recurrence of their disease. Now that shows that we may not equate that to cure, but it means that these patients are a particular subset of patients that is doing extremely well, and then we can accomplish that with a tyrosine kinase inhibitor. Now the hope is that with the new, more potent inhibitors, the proportion of patients getting into this discontinuation possible stage will increase. And so I think this would cut it for me, because then the prospect of eventually discontinuing treatment altogether, that would be an extremely important endpoint and could put these new drugs in a different category. But we need to do the trials. So,
and I think what we have right now is when you talk to physicians that take care of patients like this, is it's almost a philosophical way of looking at disease. If you have on one hand the people who take almost more of an infectious disease approach, that is, you try your kind of less, more well-known, a little bit less specific drug first, and you always keep your ACE card behind. So that's imatinib with the second generation. Then you have sort of more, the kind of oncology, high dose therapy up front as your main dose. If you're going to hit them as hard as possible. Being a transplanter, that's sort of the way I generally look at the world. But I think that argument is going to be especially interesting and provocative when imatinib becomes generic, because then people are going to want to know, how do I incorporate the cheap imatinib in the patient's care? Do you give the cheap drug up front and only treat second generation with the failures? Or do you give the stronger drug up front, almost like chemotherapy, induction chemotherapy in acute leukemias? And if you get someone into a spectacular response, give a cheap drug maintenance forever. Yeah,
that's a good point. So you touched on two very important things that I'd like to address. One, Mike, you were telling us about the potential for treatment discontinuation, and that certainly sounds very appealing. Do we have any data from the frontline studies with dasatinib, with nilotinib? It's too early to talk about treatment discontinuation, but is there any suggestion that we are getting indeed to deeper molecular responses, that we may be getting to more patients where we might be able to consider eventually this treatment discontinuation? Are we seeing any of that more molecular responses?
Well, I think that there is a pretty strong signal. I think we are getting into a deep response in more patients. That's how I would phrase it. Whether eventually these responses will be really deeper than the ones that we see in imatinib, that's a matter of debate, because we cannot really measure that very, very low level of residual disease. But there's the hope that the slope of these curves will be steeper and that eventually we'll achieve a deeper response in more patients. And, well, oncology would hold, experience in oncology would hold that this is the basis for eventually discontinuation of treatment.
And I think that, certainly for the SND, the trial with nilotinib versus imatinib, the primary endpoint was actually measured molecular response, and it certainly was met. And they've shown also the incidence of complete molecular responses, and it tends to be better so far. There was a secondary endpoint, but it's looking better. And with dasatinib, we see kind of the same trend. So, I think that, as you said, it's early, but that's the hope that we'll be getting there.
It's also true in the intergroup trial, the U.S. cooperative group trial. The CMRs are definitely higher in the people who got dasatinib than the imatinib arm. Before we leave the discussion of continuation, I just have to emphasize that these have to be done on a clinical trial basis.
Absolutely,
on what to do. We don't know the risk of people coming off therapy. Luckily, most of the people who have been discontinued, who do relapse, have responded again to drug. But if you believe that, unabated BCR-ABL signaling puts stem cells onto a path of progression, the dominant clone may respond, but you may have committed clones that are bound to progress. And we may not know what happens to those patients for 3 to 5 years from now. Sure. So this is something not to try at home.
Good point. Absolutely. Yeah.
Now, another point that had something to do with something that you mentioned earlier, Jerry. One of the comments that I sometimes hear when talking about what to use first is, if I use these second-generation TKIs, dasatinib and nilotinib first, and then my patient fails, now I don't have anything to go to. If I use imatinib, I have this as backup. If I use these other guys, what am I going to do if my patient fails? Well, how do you address that?
Well, my usual argument is that if you tried the stronger drug first, you wouldn't be having that problem. Mm-hmm. So I think that's the most straightforward way to put it. And so that's usually how I address it. And then if someone escapes second-generation drug, that population of patients may not have been treatable by any combination of drugs. Sure. That population of patients may not be able to treat by transplant.
That's true. Let me ask you about 2 other strategies that there's been a lot of discussion about. See what you think. One of them, there's been sort of a rebirth of interferon, and there's been a number of studies that have used randomization between imatinib alone or imatinib with interferon. So what do you think about those studies? Is it something that we should consider at this point? What's your opinion?
Yeah, it's the Easter of interferon. So I'm personally intrigued by the results. There are 2 trials, in honesty, that show a benefit for combinations between interferon, actually in a slow release, in a pegylated form, and imatinib in terms of surrogate endpoints, major molecular responses. But I think it's quite interesting. And interferon was the most active drug in CML before we had TKIs. So it makes intuitive sense to combine the 2. I'd be interested to learn how exactly it works. I think nobody really understands that at this point. But it's an interesting strategy. And of course, you could think along these lines and perhaps eventually maintain patients on a low dose of interferon in the absence of TKIs. So there are many strategies to think about. I'm intrigued by these results. Having said that, they are certainly not prime time. I don't think there's enough evidence to get patients started on interferon plus imatinib in 2011. We really need more data. And we'd also like to see that translate into some kind of a tangible survival benefit for the patient.
And one of the problems that we have with these studies is, when we see these kind of studies, we say, well, if the results are early, they're too early, we cannot make too much out of that. So we want mature studies, but to have mature studies, things happen in between. So by the time you have mature studies, things have changed. And that's what happened with these studies.
Yeah.
When they were designed, they were fine. I mean, that was a very reasonable strategy to try. But of course, things have changed, and now we have second-generation tyrosine kinase inhibitors, and that was not included in the study. So how does imatinib compare with imatinib added to interferon compared to nilotinib or dasatinib?
Well, that's to say that has to get done, right? To get really enthused about it, because
exactly.
right now, if we look at the data look like it'd be comparable, but a lot more toxic. Although it might be working in a different mechanism, so you might salvage some people that you wouldn't otherwise.
I think I would a little bit disagree, because in the French study, for example, many of the patients actually, I think 50% has stopped interferon altogether, and yet they achieved these better responses. So there's something odd is going on. So it's
That's
not
the next trial we were talking about doing.
right.
There you
Exactly.
All right, let me ask you about another strategy that's interesting to consider, and there is. The study from Australia, where they've taken sort of like an in-between approach. Mm-hmm. They are not starting with the second-generation tyrosine kinase inhibitors. They are starting with imatinib, but they put very strict goals that they want to achieve at early time points. And if they don't achieve those goals, then they switch them quickly to nilotinib. So it's not a failure strategy. It's a very early identification of the patients who are lagging behind and change. That's his Tidale trial. What do you think about that strategy as opposed to, for example, starting with the second-generation tyrosine kinase? They haven't been compared head-to-head, but just in general terms. What do you think about this strategy, Jerry?
I think it's a really interesting idea, and I think there's some sort of pluses and minuses about what the results are, right? The good part is that if you look at their responses, complete cytogenetic responses, and molecular responses, by taking the escalation approach, it's better than their historical findings. The thing that I think was a little bit disappointing to them as well as the community is when you look at what patients were able to go and then get a major molecular response, it was predominantly the people that were intolerant to the first drug, like the imatinib. They only had about 10 to 15% of patients who had to get switched because of actual response, who then went into an MMR. Mm-hmm. So I think they were actually hoping that a lot more would. And that, again, gets to the point that there might be a certain group of patients that no matter what strategy you have, are not going to be really cured by our therapy. You have to remember with transplantation, still 10 to 15% of patients relapse even after that. So there's in chronic phase. There's a core group of patients out there that we can't yet identify that may be resistant to pretty much everything we throw at them.
And one thing that's maybe a bit unusual about this strategy and this particular trial is that patients are being started with 600 milligrams of imatinib, which is not standard. I mean, there's been a lot of studies, but today the standard is still for 100 milligrams. So, unfortunately, we don't have the data to see what happens if you start them with 400 and then you switch that. Could it be that these patients don't respond well when you switch them early to nilotinib because you probably already pushed them enough with imatinib? So what we don't have, unfortunately, is the same strategy but with the standard dose of imatinib. And who knows if it would be different or not. That's another study that we still. So I guess we'll still have some presentations at ASH in the next few years. Now, both of you recommended for this patient a second-generation tyrosine kinase inhibitor, but I'm a physician in the community, and I'm calling both of you and tell you, all right, but there's two. Which one do I use? How can we select these? There's like comorbidities. This patient, for example, is diabetic. Are there any comorbidities or any features that can help you decide these? How can we make those decisions, Mike? What do you think?
Well, maybe the first thing to say would be that there, in my mind at the very least, there are no absolute contraindications. Mm-hmm. I mean, by and large, all these drugs are tolerated fairly well. And then in the second level of decision making, I think you can look at the patient's history, and then perhaps the most salient features that come to my mind is that patients with a history of pancreatitis with a history of diabetes, maybe badly controlled diabetes, should probably not go on nilotinib. And conversely, with dasatinib, a history of pleural effusions, a history of GI bleeding, these would be the main features that would persuade me to choose the other agent. I think in reality there's a lot of gray area. And in my mind, it's a very nice therapeutic space to have, because the three drugs are not overlapping in their toxicities too much. And one patient that has one peculiar toxicity in one agent may have nothing of this kind on the other agent. So it may just take a little bit of try and error to find that agent that is the best agent to use for a given patient.
Jerry, any thoughts about this?
No, the other thing is that in the U.S., where CML is treated mostly by community physicians, no one has a very big stable of CML patients. So often when physicians ask this question, you say, well, which drug have you used? For whatever reason, they've particularly used one second-generation drug over the other. So often if there isn't any other thing overriding it, I basically say, which one are you comfortable with? Which one are you used to seeing the side effects, used to doing the follow-up, rather than introducing them to a drug they've never tried before?
Mike, you mentioned there's no absolute contraindications. So we have a diabetic patient. You wouldn't say no to nilotinib on a patient with diabetes?
Well, I wouldn't say absolutely not, but I would say, well, given the choices I have, I might well opt for dasatinib in this case, making, I think, an educated yet prudent guess.
Okay. Well, now, so we've started the patient, and how are these things about monitoring patients? Where do we stand on monitoring? What tests should be used? How often? Has there been any changes on the recommendations as to whether we use cytogenetics or FISH, or are these out completely? We use only PCR. Jerry, you're an expert on these things.
Right. So if we talk about the general guidelines, ELN, NCCN guidelines, usually what we would recommend is to get cytogenetic analysis usually 3, 6, 9, or 12 months until people get into a complete cytogenetic remission, and then continue following at that point with peripheral blood PCR every 3 months to start off with. In general, I like to tell doctors that they should just start with peripheral blood PCR from the beginning, just so they get used to doing it. So they do it at diagnosis. I like them to do it. The baseline doesn't help that much, but I just like to get in their mind that this is an important part of monitoring. And then monitor the PCR every 3 months up till they're in a sustained cytogenetic remission. The role of FISH, if you can't get good PCR, it's not quite as sensitive as PCR, but it will actually take you down below complete cytogenetic remission, and is a reasonable alternative if you can't get PCR testing. There's various criteria for failure, suboptimal response, adequate response, which we'll talk about later. I think the shift in the field is that there's been many papers that have shown recently that if you move back the peripheral blood PCR testing as early as 3 months, you can really tell the people who are going to do badly, and those are those that really don't budge from their initial response and have an IS international scale of over 10%. And you know the ones that are going to do spectacularly well because their disease level falls off a cliff, and they have extremely low. And so those are people you can be very comfortable with your approach. And on the other end, you can have the group that doesn't budge much by 3 months, and that's the group that you have to start thinking about Plan B.
Now, you mentioned this is a threshold of 10 by the international scale. A lot of places don't have the international scale. Is there anything I can do instead of the international scale to kind of...
Right, so the international scale, there are some good and bad parts of it. Because it's rather arduous to get one, there's only probably about 5 or 6 labs in the United States that have one. That doesn't mean you actually can't use a lab. If your lab knows what the general baseline is for its assays, and you follow the patient in the same lab, it won't be exactly transferable from one lab to the next, but you'll have a very good idea of how your patient is doing. And also the international scale doesn't save you, though, even if your lab does have an international scale, if it runs in a bad assay. If you have a crummy assay, correcting that crummy number by an international scale just gives you a corrected crummy number. So so you have to kind of know the characteristics of your lab and have some confidence in it.
Absolutely. So All right, so we're getting these data about these early responses, 3 months, that value may be very important. So what do we do with that? So let's say that I have a patient that it's at 3 months on therapy, whatever I chose to use, and now I find that this patient has more than 10 by the international scale, whatever I'm using. What do I do?
Well, I mean, if you go by the book, you should have karyotyping as well. Mm-hmm. So you would have a karyotype, and you look at the response, you go to the book, you say, well, is that consistent with treatment failure? And if so, you have to think about a second-line strategy. Mm. And again, there are several options available.
Now, here is where probably the situations may change a little bit. For example, whether I'm using imatinib, right, or whether I'm using a second-generation TKI already. Right. I mean, in my mind, if I'm using imatinib, I do have something else to do. If I'm using a second-generation tyrosine kinase inhibitor, well, I do have the other one, but it's perhaps a little bit less certain that that's a step above what I have. What do you think?
I agree. I completely agree with that. I mean, the data we are talking about are really imatinib data. Mm-hmm. Right. So I think what that means in the realm of second-line treatment, not second-line, but of first-line treatment of second-line inhibitors, that remains to be seen. Now, I would think that, say, a patient treated with dasatinib or nilotinib who does not even hit an imatinib threshold at 3 months is probably in real trouble, because we applied a very aggressive treatment and it does not even hit the criteria for success in a much less aggressive treatment situation. So I would think there's a lot of concern about a patient like that. The other question, of course, is equally important. What do we have available now? And the available options are, in my mind, an experimental agent or a rather drastic thing that is a stem cell transplant. So I think in my mind, this is an evolving field, and the data at this point may not be quite mature enough to really consistently make these calls.
You made Jerry happy with that comment.
Yes, so I'm the patron saint of lost causes in transplant, yes.
Anyway, one final question before we move to the next case. So I have a patient stable, complete cytogenetic response, responding very well. How often should I do a PCR on a patient like that?
So complete cytogenetic remission.
Complete cytogenetic remission.
Usually the book would say that you do it every 3 to 6 months. Okay. And an easy way to do that is if you've got someone stable, you're going to bring them into the clinic every 3 to 6 months for blood counts anyway. You get the PCR at the same time.
You do it in the bone marrow, peripheral blood. All right, good.
Give up bone marrows.
Okay.
Once they've got a cytogenetic remission.
Very good. Well, thank you very much. So let's move now to the second debate, and what we're going to talk about here now is relapse. So, what constitutes a relapse? How should we treat relapse refractory patients with chronic myeloid leukemia? So, what we have here is a 52-year-old woman that has HLA identical sibling. It's important in this situation. Has been receiving therapy with imatinib 400 milligrams daily, chronic phase, and she has received this therapy now for about for 12 months. And after 12 months, you do a bone marrow aspiration, you do a cytogenetic analysis, you have 50% of the cells of the metaphases have the Philadelphia chromosome. So let's talk a little bit about what is a hematologic, a cytogenetic, a molecular response, and this concept of optimal responses. So what kind of cytogenetic response is relevant, and what is a molecular response, and what is relevant for molecular response? Jerry, that's your field.
So if you think of, first let's talk about cytogenetics. And so obviously a complete cytogenetic response, which is what we ultimately want, is no evidence of Philadelphia chromosomes. You have to at least look at 20 metaphases. You can't do a crummy preparation, look at 5 metaphases and call it clean. So when you leave from that and have lesser responses, you get into minor and major cytogenetic responses. By 6 months, we would declare someone a failure if they didn't have any cytogenetic response. Mm-hmm. So if they're 20 out of 20, we at least need them to go to 18, 17. Any budging of that is fine. The optimal response would be, if they were completely clean of disease. This would be a person who would be considered this kind of murky suboptimal response therapy. Mm-hmm. When we talk about molecular testing, the major milestone that we use is something called major molecular response. And what that is a 3-log reduction from a standardized baseline. This was sort of an invented term during the IRIS trial. This was actually invented at 3 a.m. on a teleconference at Pacific time, and it was where the data split on response. So there was nothing biological. It didn't come off a tablet somewhere, right? It's just a convenient way that actually correlates, though, quite well with the risk of progression and the like. So that's kind of the gold standard right now. So what we declare as a great response would be we expect you to have a major molecular response by 18 months. Sooner than that is gravy, is sort of optimal. So this person here would be sort of the suboptimal response.
All right, so let's see what happens with this patient. You mentioned that we talked about this patient, 50% Philadelphia positive at 12 months. So you see this patient now. It comes to consult to see you. How do we manage this patient? The patient is taking 400 milligrams a day, imatinib. What do? Do you stay the same? Do you increase the dose of imatinib? Do you change to one of the drugs, the dasatinib, the lotinib? Is this a patient for Jerry, for a transplant? What do you think, Mike?
So, I mean, 50% pH positive metaphase at 12 months, that would make me a little worried. Mm-hmm. I would probably say this patient is failing imatinib. I think things you always got to do is ask, are you compliant? Everybody will say, yes, I am. So it's hard to assess, but if there some indication of unreliability, that is one thing. Then it's always important to look at, especially in older patients, to look at co-medications. Mm-hmm. And at any herbal preparation somebody might be buying over the counter. If that is ruled out, then I would say, well, actually, this is not going well. And I would strongly consider a real change of strategy. In my mind, increasing the dose of imatinib is probably not the best choice. I think there are better strategies. So I would, at this point, consider switching to a second-line TKI, dasatinib, nilotinib. And if somebody's a transplant candidate, and I hadn't typed the siblings just yet, I would do it now. I would basically clear the baseline and prepare, hope for the best and prepare for the worst.
Okay. So once again, the dasatinib and nilotinib, how do I choose from the patient who's developed resistance to imatinib? Any suggestions, Jerry?
Well, this is a patient that you would probably be reasonable to do mutation testing on, mm-hmm. To see whether or not they've had an acquired ABM mutation. And while it's not perfect, there are tables where you can look up basically the inhibitory concentration of the various compounds versus the mutation type. And often they correlate well. So if you have a patient that has supposed to have a sensitive mutation and you give them the drug that's appropriate for that, they'll respond. Sometimes you get a red herring, mm-hmm. and they don't, which just shows that there's a lot more to it than we know. So I think if nothing else is driving us one way or the other with toxicity stuff that Michael talked about, the actual type of mutation you have would be suggestive. If there's no mutation, which happens 50% of the time or more, then you go into the things that we talked about before, but Michael talked about, whether there's other side effects, whether if there's a reliability issue, 1 dose a day with dasatinib versus 2 doses a day, things along that line.
Rosie, what can I expect from the second-generation tyrosine kinase inhibitors? The response rate is, the complete cytogenetic response rate is around 50%. So we have very good strategies, but they're not perfect, right? I mean, there's a number of patients. We can select them by mutations sometimes. Other times there's no mutation, or there's a mutation with no information. So I think it's important that we need to keep monitoring these patients very closely. Once we started, the clock starts ticking again. So if we already went to the every 6-month PCR, we need to start from the beginning now, right, and start looking at their cytogenetics and their PCR and all of that, because not everybody responds. It's a serious situation, and I think the issue about the HLA typing becomes very critical, because you want to be prepared, especially in a young patient that may have that option. I think it is fine to start the second-generation tyrosine kinase inhibitor, but if they're not moving along well, you need to be ready to act. Would you agree?
Oh yeah. I mean, at our institution, how we usually play this is if there was a person that we demanded a second-generation drug for salvage, not only would we do the HLA typing of the siblings, but if there wasn't a match, we would probably start an unrelated donor search at that time. How long you keep someone on a second-generation drug before you declare victory or failure, there's been a couple of studies. At the MD Anderson, your study suggested that at 12 months is a pretty good indication of how long, if you've had, at Hammersmith, they demand a response by 3 months. So I think that what the actual perfect data point is probably, who knows, but I think from a practical standpoint, what you can do is most unrelated donor searches take from 3 to 5 months to complete. So you can actually start the typing, look for a search. At the time they have a donor, you can actually do a reassessment there. And if they're definitely heading in the right direction, you can basically hold off. But clearly, if they're not making much budge by 3 to 6 months, they're not going to. And at that time, we'd probably go for a transplant if we had a good donor.
And perhaps how strict do you go into how demanding you are on the response probably depends on the scenario. I mean, if it's a 20-year-old with a matched sibling, yes, absolutely. 3 months, no good response, you need to move on. If it's a 72-year-old patient, that you need to be a little bit more patient because there's probably not much else.
Because the risk of the transplant is so much higher, sure.
Exactly. All right, so let's put a hypothetical scenario on these patients been receiving therapy now with imatinib for 18 months. It's been in complete cytogenetic response, but has not achieved a major molecular response. How much do we need to put on this no major molecular response on a patient who's complete cytogenetic response, no major molecular response? We've called this the suboptimal response. What do you do with these patients, Mike?
Well, I think that is probably a question of a hot debate. So I think maybe it's almost a philosophical question that is hard to answer in any dogmatic way. There are two studies that have suggested that if you're not in a major molecular response at 18 months, you have a higher risk to lose your complete cytogenetic response as compared to patients who are in a complete cytogenetic response plus a major molecular response. And that risk was about 25% as compared to 3% in two studies that delivered very, very consistent results. Now, based on that, you could argue, well, everybody not in MMR at 18 months should actually be moved in some way to some more aggressive treatment. Others would argue that as yet it remains to be proven that waiting it out is associated with any adverse outcome in terms of overall survival, and have argued that, as long as we don't have that data, there really is no reason to change these patients. And I would probably agree with that, because at the end of the day, you really need to understand whether the intervention you propose is actually positively influencing the outcome. And we are making a lot of assumptions here. So my take on that would be complete cytogenetic response at 18 months, get the next PCR at 3 months' time and see where things are then. I would not switch.
Would you switch? Would you do something different?
Well, as at these contrived debates that we have at meetings, you and I have debated this twice at opposite ends both times. So it's obviously a debatable topic. I think some of it also depends on how the patient views their illness, right? There are some people who want to be very, very aggressive, some that don't. And it might have something to do with age. I mean, if you have someone who's young and you say, I want to kind of keep them from progression for 30, 40 years, hedge your bets. If you have to put your money on the table, which way do you think is going to be better? Versus someone who's 65, and I really don't want to get reasonably that far out. And there you don't want to do any harm, right? So I think that a lot of that nuance comes into it.
Yeah, I mean, I've been more on the side of you can be conservative on these kind of patients, but I think the one thing that we should we probably all agree is that that's the kind of patient that you do want to make sure that you're monitoring closely because that's a patient that can go either way. So that's one thing that you definitely need to do. Intervention, there's different scenarios. So let's say that the patient now clearly has lost the response. And
I made a mistake. Are you saying I made a mistake? Yeah, I made a mistake.
You made a mistake. You made a mistake. So, but let me. So we've treated the patient. We've given we've did imatinib, then we switch them to a second-generation tyrosine kinase inhibitor. You choose whichever you decided to choose based on your mutations, whatever. But now the patient has failed that second-generation tyrosine kinase inhibitor. What do we do now? Now you still have one other tyrosine kinase inhibitor, second generation. How much we can expect with that? What are the options?
Well, let's assume failure not based on intolerance, but failure based on resistance. So like lack of a response. Well, I think by and large, the second-line inhibitors in the third-line setting are not very effective. There are cytogenetic responses in the range of 25% in some studies, but I think many of these responses are not maintained. Mm-hmm. I think it would also be a good opportunity to get another mutation test to find out whether there's the so-called 315 mutation, 359 mutation that confers resistance to any TKIs that is currently approved. But my conclusion would be that this patient is clearly in trouble, that the available options that are approved other than transplant are not going to be in any way definitive. So I would look for a study, I would look for an investigational agent, and I would very strongly consider allogeneic transplant, perhaps using an investigational agent as a bridge to a transplant to get a better response, a better starting position before a transplant.
Let me make you suffer, Jerry. There's no donor. So any interesting drugs that you've heard about on the, for patients that are in this situation, no option for transplant?
Well, if you talk to some of my transplant donors, there's always a donor.
All right.
But let's say that cooler heads prevail.
Okay.
I think that the two promising drugs out there is bosutinib, which has been used in this setting as well as in a frontline setting. In the frontline setting, it looked like it really didn't pass the muster in the clinical trial versus imatinib. Although, curiously, I think a lot of the reason is that a disproportionate amount of patients came off that trial because of GI toxicity than would be expected. Mm-hmm. So, in a setting like this, it does have activity. There are cytogenetic responses, 30 to 50%, and in most of the mutations spectrum, it covers except the T315I. So that would be one option. And then ponatinib, which is a pan-ABL drug, it basically covers all the mutations, including the 359 mutation, quite effectively, would be another option that I think that would be a good one for a patient like this, because I think clearly has cytogenetic responses and the whole array of mutations that you can throw at it.
Yeah, the data on ponatinib looks very exciting. I mean, of course, these drugs, bosutinib, ponatinib, are not available today, but we're hoping that we will have them available hopefully soon, and that'll be an important addition because, as we've been discussing throughout these cases, we certainly have good treatment for the majority of patients, and between starting with a good front line and sometimes the need for salvage, but we are getting to some patients that are having trouble. Perhaps, as we discussed, some patients we're going to be able to salvage with yet another tyrosine kinase inhibitor, and I think we all have agreed that we are going to find some patients that it's not a tyrosine kinase inhibitor, and perhaps not even a transplant, because there are a subset of patients that do transplant even from first chronic phase from the beginning, and they don't do well, and there's something in the biology of these patients that's just different, and we just need to understand better. So I guess we still have a few things to do, and perhaps we will still have another ASH with CML, at least one more, I would imagine. So I will see you here next year.
You can't get rid of us that easily.
Probably not.
You're right.
Okay. Well, thank you very much. I think this was a very fruitful conversation. I think there's a lot of important observations. I think we can make our patients do very well. The majority of patients, it is important to do good monitoring, to explain all these things to the patients so that they understand what we're doing, what the objectives of the treatment are. And if we use all our tools for monitoring, for treatment well, most of our patients are going to do well. And of course, we need to work on the ones that don't do well. So thank you very much for your attention today. To receive credit for this continuing education activity, please complete the post-test and evaluation. Thank you very much for watching this program.